Hello, everyone, and welcome. Today, we'll be diving into the world of drugs used to treat inflammation, pain, and fever. This is a crucial topic for all healthcare professionals, so let's get started. In this presentation, we'll cover several key learning objectives. We'll explore the underlying causes of inflammation and fever, understand the role of chemical mediators, and delve into the neural mechanisms of pain. We'll also examine specific drug classes and how they work, including steroids, NSAIDs, acetaminophen, opioids, and opioid antagonists. Finally, we'll discuss how to apply the nursing process to patients receiving these medications. Let's begin by defining inflammation. It's a natural, non-specific defense mechanism our bodies use to respond to injury, toxic chemicals, heat, microorganisms, or cell death. The primary purpose of inflammation is to contain the injury or destroy any invading microorganisms. Inflammation can be acute, subacute, or chronic, each with varying durations and functions. Physiological inflammation plays a crucial role in resolving inflammation and maintaining homeostasis. Understanding these different types is key to effective treatment. Acute inflammation follows a series of steps after cellular injury. Chemical mediators like histamine and bradykinin are released, leading to vasodilation, increased vascular permeability, cellular infiltration, and clot formation. This process also stimulates nerve endings, resulting in pain. Histamine, released from mast cells, interacts with histamine receptors throughout the body. This interaction can lead to gastric secretion, vasodilation, itchiness, and contraction of respiratory airways. Understanding these effects helps us anticipate potential side effects of medications affecting histamine. The 5 cardinal manifestations of inflammation are heat, redness, swelling, pain, and loss of function. These signs are essential for recognizing and assessing the severity of an inflammatory response. Inflammation can manifest locally or systemically. Local inflammation presents with specific signs and symptoms at the site of injury, while systemic inflammation involves the entire body. Treatment strategies differ depending on whether the response is local or systemic. Fever is a nonspecific cellular and chemical response that helps the body fight infection. It stimulates increased white blood cell production, decreases available iron for pathogens, and introduces interleukin-1. A temperature above 38 degrees Celsius or 100.4 degrees Fahrenheit is generally considered a fever. Cyclooxygenase or COX enzymes play a crucial role in inflammation and pain. COX-1 is involved in maintaining normal physiological functions, while QX2 promotes inflammation. Inhibiting QX2 is desirable for reducing inflammation, but inhibiting QX1 can lead to adverse effects. Pharmacotherapy for inflammation involves 2 major classes of drugs, corticosteroids and NSAIDs. Corticosteroids are used for acute severe inflammation, while NSAIDs are used for mild to moderate inflammation. Both classes work by interfering with the production of inflammatory mediators. Systemic corticosteroids, like prednisone, betamethasone, and hydrocortisone, are powerful anti-inflammatory agents. Notice that many of these medications end in 1, which can be a helpful memory aid. Systemic corticosteroids are effective in treating severe inflammation by suppressing histamine and prostaglandins and inhibiting the immune system. However, they also have serious adverse effects, including masking infections and causing hyperglycemia. Prednisone is a commonly used systemic corticosteroid. It's crucial to administer it cautiously in patients with infections, and to taper the dose gradually if used for more than 10 days. Long-term therapy can lead to serious adverse effects like Cushing's syndrome and osteoporosis. Prolonged steroid use, particularly with prednisone, can lead to a range of side effects, including emotional disturbances, moon phases, buffalo hump, and osteoporosis. It's important to be aware of these potential effects when managing patients on long-term steroid therapy. Prednisone interacts with several drugs including barbiturates, phenytoin, and rifampin. Herbal interactions include aloe, buckthorn, and senna, which can decrease potassium levels. Always consider potential interactions when prescribing or administering prednisone. Now, let's shift our focus to pain. Acute pain is often associated with the fight or flight response, while chronic pain can lead to adaptation and decreased blood pressure and pulse. Understanding the differences between acute and chronic pain is essential for effective management. Nociceptive pain results from the normal processing of noxious stimuli by the sensory nervous system. It can be somatic, which is sharp and localized, or visceral, which is generalized, dull, and aching. Neuropathic pain, on the other hand, arises from abnormal processing of stimuli in the absence of tissue damage or inflammation. It's often poorly localized, difficult to manage, and resistant to first-line analgesics. Pain transmission can be interrupted at various points along the pathway from peripheral nociceptors to the brain. Pharmacological interventions, such as opioids, alpha-2 agonists, and local anesthetics, can target these points to provide pain relief. Non-opioid analgesics, like NSAIDs, are used for mild to moderate pain associated with inflammation. They also reduce fever by inhibiting COX enzymes and prostaglandin synthesis. NSAIDs include aspirin and other salicylates, ibuprofen and similar drugs, and COX-2 inhibitors. Celecoxib, a COX-2 inhibitor, should be used with caution due to FDA review. NSAIDs can cause a range of adverse effects, including hypersensitivity, GI effects, circulatory effects, and renal effects. It's important to assess patients for risk factors and implement interventions to minimize these risks. Ibuprofen is a commonly used NSAID with analgesic, anti-inflammatory, and antipyretic properties. Be aware of potential side effects and contraindications when administering ibuprofen. Aspirin, a salicylate, is another widely used non-opioid analgesic. Remember that tinnitus can be a sign of toxicity, and aspirin should be avoided in children due to the risk of Reye's syndrome. Aspirin's pharmacokinetics, lab test interactions, and herbal food interactions are important considerations. Be aware of potential bleeding risks and interactions with other medications and herbal supplements. Centrally acting non-opioid analgesics like acetaminophen, tramadol, and ziconotide are used for mild to moderate pain and also reduce fever. Each drug has its own specific route, dose, and potential adverse effects. Acetaminophen acts directly on the hypothalamus to reduce fever and treats mild to moderate pain. It has no effect on platelet aggregation, GI bleeding, or inflammation. Always educate patients about combination OTC products containing acetaminophen. Acetaminophen can cause serious adverse effects, including liver toxicity. Be aware of potential drug interactions and the availability of N-acetylcysteine as an antidote for overdose. Genetic polymorphism such as G6PD deficiency can increase the risk of acetaminophen toxicity. Use caution in patients with G6PD deficiency and monitor for signs of anemia. Nurses play a crucial role in administering non-opioid analgesics. This includes pain assessment, monitoring the patient's condition, providing education, and assessing for hypersensitivity, bleeding disorders, and other contraindications. Now, let's discuss opioid analgesics. These are natural or synthetic morphine-like substances that reduce pain. Endogenous opioids and endorphins also play a role in pain modulation. Opioid receptors, including mu, kappa, and delta receptors, are located in the brain, spinal cord, and digestive tract. Opioid agonist drugs stimulate these receptors, producing analgesia and CNS effects, while opioid antagonist drugs block them, reversing CNS effects. Mu receptors are associated with analgesia, decreased GI motility, respiratory depression, sedation, and physical dependence. Kappa receptors are associated with analgesia, decreased GI motility, and sedation. Understanding these receptor effects helps us anticipate potential side effects of opioid medications. Opioid agonists vary in their effectiveness for pain management. Common adverse effects include pruritus, sedation, nausea, and constipation. Serious adverse effects include respiratory depression and abuse potential. Morphine is a potent opioid agonist. Be aware of administration alerts, black box warnings, and contraindications when administering morphine. Morphine's pharmacokinetics, adverse effects, drug interactions, and herbal food interactions are important considerations. Be prepared to manage potential adverse effects and interactions. Opioid antagonists like naloxone and naltrexone are used to reverse the effects of opioids. Be aware of potential withdrawal symptoms and hepatotoxicity. Naloxone is a crucial opioid antagonist used to reverse opioid overdose. Understand its actions, uses, adverse effects, black box warning, contraindications, and interactions. Opioids with mixed agonist-antagonist effects like buprenorphine and butorphanol may be used to treat opioid dependence. These medications can help avoid CNS symptoms and withdrawal symptoms. Assessments and nursing implications are crucial for patients taking acetaminophen, NSAIDs, and dual adjuvant analgesics. This includes assessing liver and renal function, medications, GI history, vital signs, and level of sedation. Pharmacologic interventions for chronic neuropathic pain include adjuvant analgesics like anticonvulsants, antidepressants, local anesthetics, and peripheral nerve blocks. The goal of pain management is for the patient to exhibit pain control with limited side effects and no dependency. Patient education is essential to ensure adherence to prescribed medications. Let's test your knowledge with a few fill-in-the-blank questions. What is the maximum mg day of acetaminophen? And what is the maximum mg day of ibuprofen? Here's an application practice question. A patient with hepatitis B is prescribed hydrocodone with acetaminophen, Vicodin. What is the most appropriate action for the nurse to take? Another application practice question. In which of the following patients is acetaminophen preferred over aspirin? Thank you for watching. We hope this presentation has been helpful in understanding drugs used to treat inflammation, pain, and fever. Please subscribe, like, and share this video with your colleagues.